Welcome to all. I'm Giovanni Mosiello, and nice to meet you and to have you again with us. And today we have this presentation, this webinar, that we hope really that will be interesting for you, because it's the presentation of a new platform for discuss together and with experts of Western Europe, but of course from Ukraine, because we are colleagues with different history on our background, but we are all involved in the care and the cure of spinal bifida patients, and this platform will be useful for us, will help us to join our effort. A special thanks to Eurogen staff that permit to organize this webinar, to the International Federation of Spinal Bifida that created this joint venture between Ukraine and Eurogen, and of course to Omninet that represent the care and cure of spinal bifida patients in Ukraine. Today, as you have seen by the slides, we are many people, and we are many people to introduce this platform. And I would like to leave the podium to Dr. Zymak. Please, thank you very much to be there with us. Please, Dr. Zymak.
Greetings. Вітаємо. Ми раді бачити вас на продовженні серії вебінарів Україна-ЄС про спінальні дисрафізми. Організаторами цієї серії є ІРН Євроджен за підтримки Міжнародної федерації спінобіфіда та гідроцефалії, Європейського товариства дитячих урологів та Омні мережа України. Нагадую, що кожен, хто відвідає вебінар онлайн і заповнить опитування після вебінару, отримає сертифікат участі та 1 бал міжнародної акредитації, якщо заповнить опитування по закінченню вебінару. Для нашої української аудиторії хочу наголосити, що у разі повітряної тривоги просимо вас негайно перейти в укриття. Перегляд запису вебінару та відповіді на питання будуть доступні згодом. And now it's my pleasure to give floor to Professor Giovanni Mosiello.
Dr. Zymak, and as you have seen, today there are many speakers, and there is with us Professor Rаймундом Стайном, that you know very well because you have met in the previous webinar. And we have two new entry, two young colleagues that will help us to discuss these cases, and I'm very happy for this, because it's not easy to involve people in the presentation of in the management of spinal bifida cases, and this means that we are able to motivate people for a long-term follow-up of these patients. And as guest star, we have Darren Shilhan that is with us, is the expert of this platform. So I would like to invite him to start the discussion and the presentation. Please, Darren, the podium is yours.
Thank you, Giovanni. Hello, everybody. So I'm going to talk to you today a little about this new system, or new version of the system called CPMS that Giovanni mentioned. Sorry, I think I've got my apologies, 1 second, messed it up already. So this is going to focus specifically on what Ukrainian clinicians, how they can utilize the system. As much as what I'm not going to do today is not a training session to tell everybody exactly how everything works in the system, just to give a high-level overview of how the system works. So the CPMS, as we call it a lot of times, stands for Clinical Patient Management System. It is a kind of web-based tool, so you just need your browser to access it, and it's provided by the European Commission in order to facilitate the discussion of these complex cases, either rare or low prevalence complex diseases or conditions. Obviously, we focus in Eurogen on the urological aspects, but there are 24 ERNs covering all different aspects of health. So all of those will be contactable. The idea is that it provides a secure platform where you can upload patient data, but you can do it securely. This enables then basically a virtual NDT discussion, various experts from varying disciplines or areas of expertise, and then we can provide that advice to you, the treating clinician, which you need to treat these complex cases, which you may have not come across previously. We have a lot of experts already signed up to the system. They're already ready to use CPMS. We've had a previous version of this where people signed up, but they're all still on the new system and ready to offer advice to clinicians who might be dealing with these complex cases for the first time, as I was saying. So one important thing is, as long as the treating clinician obtains the consent of the patient, which we'll come to a little bit more later, then any clinician based in the EU can submit cases to the system. But more importantly, and why we're here today, is that this is now available to be used by clinicians in Ukraine as well. This is the first time it's been available to anybody outside of the EU. Okay, so a little bit about how CPMS works. This is a very general introduction which would apply to kind of more EU-based users, I would say initially, but I will come on to the differences with Ukrainian users shortly. So as a clinician, if you've got this rare or complex case that falls within the remit of one of the ERNs, as I say, there are 24 together, but you can then upload your case to CPMS 2.0. So this is the new version that we're mentioning. It was actually only launched in November 2024. So we are just starting to use it now. And it's designed also, built into this system was the ability for Ukrainian colleagues to join. All the necessary legal aspects have been taken into account with the new system, hence why we're able to offer it as a resource to Ukrainian colleagues. So basically, yeah, what happens is we've got a little flow at the bottom there, which shows kind of what happens. Basically, you, the treating clinician, obtain your patient consent. You submit the details of your patient to the system. We'll go through how people join the system later. That creates a discussion within the system. We then, as the RN, would invite relevant experts to look at that case that you've submitted. They would then have a discussion and basically come up with a conclusion, a set of recommendations based on the information they have and their discussions. And then we can provide that back to the treating clinician as a summary of the advice. So that's kind of a high-level overview of how this works. One thing I have put there is, please be aware that it should only be used by health professionals. It should not be used. This is not accessible by patients, and patients should not be included in the any discussions or involved with the system. Okay, so patient consent I've mentioned already as being very important. The thing you need initially to get the case started. You can't submit a case without doing this. So there is a bit of a different process again between the EU and the Ukraine in this, because of the agreement we have that was made this happen. So on the EU patient consent form, there are actually 3 boxes that can be ticked. The consent for care is the one that allows the case to be put onto CPMS, but they also have one for education and consent for the information to be exported to a registry later on down the line. And also the HCP in question, or the hospital rather than HCP, would manage that form themselves as well. They would keep hold of the form and store it in the patient files. For the Ukrainian patient consent form, there's only one box to tick for mandatory consent, which is that consent for care. So all we're doing here is saying that the patient is willing to have their case discussed in CPMS. There's no question of it being used further on down the line for anything else. And also, while the European UA form can be consent form can be adjusted. The Ukrainian one cannot. It must be stay as it is. And also we'll see in a minute also that the consent form is managed slightly differently in terms of it being registered with the so-called UA hub, which I will mention on the next slide, I think. So this is a little bit about the process now specifically for our Ukrainian users. So-called administrative arrangements between the European Commission and Ukraine was signed on in February 2024. This then allows the use of CPMS 2.0 from Ukrainian territory. So as part of the agreement, so I said the Ukraine Rare Disease Hub, we will term it here, know it as the UA Hub in the rest of the presentation, which is based in Kiev, should be the first point of contact for any Ukrainian clinician who wishes to submit a case to our experts for discussions and consideration. So I put there, that's the email address of the hub. So if you are a Ukrainian clinician in Ukraine and you want to submit a case, this is the email address you should use in the first instance to send details, initial details of the case without any identifying patient data. I should say this is really to kind of let the hub know that there's a case going on. The hub's job is to have a look at that request and assess whether it is medically valid, which means does it concern a rare or low prevalence complex disease or condition that falls within the scope of one of the ERNs, because that's what the ERN's rationale is for being there. If that does, if the hub accepts this, the hub will contact the relevant ERN. There's no contact directly between the clinician and the ERN at this stage. The hub is acting as an intermediary between the two of us. So the ERN, once the hub will then contact, say, the ERN. The ERN themselves will have a look at the details that they have, the brief description, to make sure it kind of falls within their remit. If they confirm that it does, they will also confirm back to the hub that they are willing to, they're available to discuss it and willing to discuss it. And also they give a name of a contact person at their end or our end as the ERN that will be the liaison with the Ukrainian clinician. So once the UA hub receives that confirmation back from the ERN, they will send the consent form that can be used to send it to the UA clinician, the treating clinician, for them to obtain the consent from the patient. So basically, as a clinician, you will need to get that consent form signed by the patient, and you will then need to send it back to the hub. This can be done electronically as well. So although you need to get a person to sign it, it can be sent back electronically. If the consent is that's all, again, the hub accepts that it's all been done correctly, they will inform the clinician of the contact person who the ERN named and authorize them to make contact. So what we're going to now is say, how does this part of the process happen? How does the contact actually occur? So accessing CPMS itself. So yeah, once authorized, a Ukrainian clinician should needs to request guest access to the system, to CPMS 2.0. You will get the link at that point as well. Before you actually get into CPMS itself, it's necessary to have an EU login. These are kind of logins that are used for many different systems, but CPMS requires that you use an EU login to access it, and also requires that you have double factor authentication as well, which means rather than just having a password, you also need to have some other way of confirming your identity. This is usually done on an app on a mobile phone, which is the most common way these days, and it's the easiest way for most people to do it. Once that's done, you'll see, then you can actually basically, once you've done your e-login, you can then actually access CPMS 2, and you can make that request to the ERN. This is basically to request access to CPMS itself, and also be linked to the particular ERN that your case has been referred to. So when you make this request, you should be able to do that easily. When you log into CPMS for the first time, it will basically say that you need to sign up, and you will go through the registration process. I'll put a little screenshot here of kind of a little bit what it looks like, the start of it, not all the screens, but it gives you the idea of what you're filling in, and then you're choosing an ERN to send it to. So when the ERN has authorized you, you'll be able to log in properly as a guest user. This then allows you to carry on with the process. So the idea at this point would be that you would then enroll the patient. The first thing, I've got it on the next screen, but I'll show you in a second. You need to confirm that the patient consent was given. You also then build the rest of the patient case by uploading. You can type in a text description of what the case is, or you can also add lots of different types of document, depending on what you've got, images, medical images, etc. They can all be added to the system as well. The point is to give enough information to the experts to be able to make an assessment of the issue that you're raising with them and that you want advice on. So the UA, next step. So the UA clinician uses the chat function within CPMS to contact the contact person that the ERN's named. So yeah, rather than doing it outside of the system, you're doing it all within CPMS. So when you get into CPMS, once you actually have access, don't worry, because we're going to send you more information about how to actually do these little tasks and particular tasks. I didn't want to show you all today because you'll forget it again by the time you need it. So we'll kind of provide more information on those things at the time. But there's a chat function within CPMS that you can use to then identify the person. You'll be able to find them in the system. They will be on CPMS as well, and you'll be able to send them a message. Then you have some contact with them, agree a way forward about the case, how you want it to be discussed. All the discussion takes place again within CPMS, within the secure platform. You can be aimed at, you can choose, you can say whether you're looking for help with a diagnosis, help with treatment, or possibly both of those things. Important to say there are two ways to do discussions. Either I'll show you some of the screenshots shortly, but they can be either text-based, the experts just typing in their opinions, which is useful for people because it's difficult to get people together at the same time. But otherwise, if we can get people together, we can also have a video meeting to go through the case. We've had good experience with these in the past. They work very well. But as I say, sometimes it is difficult to arrange. But the choice is there which one you want to do. And often we use a hybrid of both, where we'd have a video meeting for a number of the experts, but others can then either watch back the recording or just simply comment in addition to the video meeting. So once the case is kind of been discussed, we as ERN will decide, okay, the discussion has happened, has come to a relevant conclusion. We will then generate an outcome report, which summarizes the advice from the experts. We will then provide this back to you. You can download it as a PDF document. And then the final thing we do is important to realize is that your guest access, once the case is finished, will be deleted. So that is assuming you don't have a second case ongoing. If you don't, then that will be deleted. You would have to apply just for access again, but it would be just the last bit of the process of logging in, applying for access again to the ERN who would authorize it. Everything else would be, obviously you'd have to go through the hub again to raise the case, but it would be a lot easier the second time. Okay. So just going to quickly show you some screenshots as we come to the end of this. Also, it's not a training session, this showing you everything the system does, but it's just showing you an idea of what it looks like in terms of the things you might come across. So this is what I mentioned earlier, this little screenshot here, the first kind of thing that's circled is showing you that you'll be asked, the first thing you're asked when you try to upload a patient case is, have you got the consent? So you'll have to kind of tick that box or check the box that says yes to say you have. Yeah, those other boxes there will be irrelevant for you as Ukrainian clinicians, as they are not on the form for the Ukraine consent form. You then basically provide basic details of the patient. This is kind of actually, it will be their kind of first name, last name, etc. This is called the identifying data. This won't be available to anybody else, only those that you deem can see it. If anybody, so it's usually somebody, if you have some clinicians in the system can have assistants, they will be able to see that data, but it will be limited to people in your center and those who you designate. So what actually happens is when the system creates it, they generate a nickname for there's an auto nickname generated, a nickname auto-generated in the system. You can actually change that if you wish, but that's how the patient discussion, that's how they will be known to the experts. They will never have the real name of the person. Okay, yeah, you add your details at the center, specify the kind of area that it is covered in. So we already know which ERN should cover it, but you can be more specific about which kind of area it is within that ERN, and that would help us, for example, initially to invite the right people to the case. This is then what we see in terms of the sorry, I'm taking too long, Giovanni, apologies. I don't know. I'm nearly finished. So yes, we have like this is what the discussion would look like. It's basically when we designed it, we thought about kind of what does WhatsApp look like, that kind of thing, where you have this, there's a topic at the top that you would put in to describe the issue that you want help with. You could also and then basically experts will comment underneath that in the case. That's one way of them giving the advice, and they would discuss it amongst themselves in there as well. As I said, you can also add lots of different documentation. This just kind of summarizes the kind of many of the types of attachment you can put on. So if you have like the medical images, you can upload those. If they're just office files with summaries of the case, we upload as well, images, even video files if necessary. So that's as far as I'm going to go today. This is what the system looks like. I've also added here at the end a quick process summary just to kind of summarize all those other slides as to the path that it goes through. What I've also done is added a PDF of these slides to the lobby, so you should be able to download those and take them away with you to read later on, and hopefully if need necessarily translate. I was thinking maybe putting a Ukrainian version and sending that out to people as well, but hopefully that will gives you a good overview of what the system is and how it works and how you will be able to access it once you contact the hub. Okay, thank you. Giovanni, back to you.
Thank you very much, Darren. Very, very clear. And first of all, before some questions, and I would like to thank Professor Faith that I've seen that is with the attendees. Professor Faith create Eurogen, and I am very happy to have him with us. And as I'm very happy to have with us today Dr. Sylvia Rosen, that is the General Secretary of International Federation of Spinal Bifida, and Michel Battier, that is Administrative Coordinator of Eurogen. And I'm happy for this because this represents well how Eurogen have care of this project, and we hope really that will be helpful for you. And Dr. Zymak, do you have any comments for the presentation, please?
I haven't any comment. Thank you.
I think yes, one quick question. I think Michelle Batty has put a question into the chat, Giovanni. So I just might be answer that. Can Ukrainian clinicians share the outcome report with their patients so they can discuss what advice is recommended? Once the advice has been given back to the treating clinician, they are free to discuss that with their patients. It's their responsibility as well to decide whatever they decide to do with that information. The information is given as best we can based on the evidence we've seen, but it's up to the treating clinician ultimately to decide what to do with that, whether they follow that advice. There's obviously no obligation for them to do so. The choice is theirs. The responsibility then rests with them to decide what to do with it going forward.
Thank you, Darren. And I believe that we can start, if we don't have any more questions, with the practical presentation. I would like to invite Dr. Luisa Weil, that is working in Mannheim with Professor Stein, and is a pleasure to have you with us. And so please, I would like to invite the colleagues from Mannheim to present their cases that will be helpful, I believe, for the colleagues to understand how does it work. Please, Dr. Weil, the podium is yours.
Okay, so thank you very much for the introduction, Giovanni. And I would now like to present our first example case. Just trying to share this screen correctly. I think now everybody should be able to see my screen. And yes, so I created an example case. It's no real case, but it's similar to many patients we do see. And I wanted to show just how this could look like, what kind of cases you could put up in the CPMS system in order to get expertise on the further treatment. So in my clinic, a 6-month-old female visited. She was born with a spina bifida aperta, and the patient history shows that the neurosurgeons did the patch closer on her first day of life. In the following, she was necessary to receive a ventriculoperitoneal shunt. So far, there's been no bladder management. The mother, though she's observed the girl only dribbling the urine, she's not really seen a urine stream. There's no history for urinary tract infections, and she's not taking any medication so far. This was our first VCUG of the bladder. As you can see, there's no reflux, and the bladder does look okay to me. You can see the shunt in the picture. And now we did our first urodynamic. And in the first filling, we were only able to fill 9 milliliters, and we saw these contractions of the detrusor, or maybe is it just a reaction of the girl or trying to void. In the second measurement, we were able to fill a little bit more, 26 milliliters. But again, we do have this kind of contraction I marked with the red, and is this a detrusal contraction as in autonomic contractions, or is it just the girl trying to void? This would be my questions I would ask the experts. What about the bladder volume? In the first measure, I was only able to fill with 9 milliliters. Then in the second, we were able to fill with 26 milliliters. Can we say anything about the compliance of the bladder? There's no reference for children at that age. So how should I proceed? What should I recommend? The mother, should we start with CIC? Should we put her on oxybutynin or something else? Should the girl receive antibiotic prophylaxis? And this is the first, example case I would use the CPMS for if I'm really not used to treating patients with the spina bifida. And I continued the case because 10 years later, she came back. I did put her on oxybutynin, and she was able to do CIC, but then she didn't really lose urine anymore, and she didn't do the CIC so regularly. She did take oxybutynin, but there's been no more urological contact, and now she comes back to our department because she has recurrent urinary tract infections. We again do a VCUG, and now we do see a very high grade reflux, and we have this urodynamic of the patient. And again, to the CPMS, what would my questions be? So how do I manage the bladder now? Is the CIC enough, or do we need nighttime drainage? should we use more anticholinergics? She is on oxybutynin, but the dosage is rather low. She's only 0.3 milligrams per kilogram. Should we start with Botox now, or should we even think about urinary diversion, augmentation? What's better, to do a continent or incontinent stoma? So this, to me, are very special cases, and only an expert could really help me with this. So now I'm finished with my presentation, and I'm now going to take my screen back off. Hold on.
Okay, thank you very much, Dr. Weil. Very interesting case that suggests some point for discussion that could be very helpful in daily clinical practice. Because at the beginning, we have a girl that theoretically was not a risk, and we have to consider that maybe is not so common to perform urodynamics or video urodynamics in all centers, and maybe the suggestion, the discussion could be related to which is the correct approach with these children. How Professor Stein, that is one of the members of the panel of the guidelines for the European Society of Pediatric Urology, well defined, is very important to have a proactive approach to the patients, because also if at the beginning there is no sign of dysfunction, because it's easy to observe the pee in the pad, so theoretically there is no dysfunction, and maybe at the beginning also the UTI are not so common, and time after time it's possible to have a dysfunction. And it's important to remember a difference between children and adults with a spinal lesion, because the children with a spinal lesion grow up with a spinal lesion. So of course we could observe a secondary tethering, for example, that could be the cause of the bladder dysfunction. And so the recommendation is of course always to have a continuous monitoring, and it is possible to start also with a proactive approach. And do you have any comment, Dr. Zymak? No? Okay. Professor Stein,
No.
do you like to comment the first step of this case? No.
No, very interesting case. Yeah.
Okay. And Dr. Zymak, is common for you to perform urodynamics in all the center? There is a urodynamic unit or not?
Unfortunately, no. Some centers in Ukraine has this possibility.
Okay. Professor Stein, what is your recommendation if in one center there isn't the opportunity to perform a urodynamic? Which study do you suggest for evaluating the bladder function, and instead the urodynamic, that of course is the best, as is the best the video urodynamic?
I think the first thing with these patients is, and that what is written in the guidelines have clearly shown, is that you really have to be proactive and start very early with the treatment, and this means to CIC and getting anticholinergics. I think there's no need for antibiotic prophylaxis except there is reflux. What you can do if you don't have high sophisticated urodynamics, you can make small urodynamics, which means you can put in a catheter and see how the pressure maybe in the bladder, just having a ruler beside the catheter and these things. So you see if there's a high pressure or not. But leaving the child without any treatment, even in the first run, I think 80 to 90% will end up with a neurogenic bladder, which needs this treatment. And I think it's even more than 80 to 90%. I think in the end, most of them, when they have higher lesion, will end up with some kind of neurogenic bladder dysfunction. So if you don't have these urodynamic things, you can make a very simple urodynamic, but I think you should still start with treatment as early as possible.
Thank you very much. And Dr. Weil, so we can summarize that in case that there is a request for evaluation, for a second opinion, in this case, the recommendation that could be suggested to the families is to start as soon as possible the intermittent catheterization and to start oxybutynin, also without UTI or also without evidence of a bladder dysfunction, because the suggestion that could be recommended in this case, also with the support with other colleagues outside the Ukraine, is to start with a proactive management. And for the second part, Dr. Weil, you could be so kind, yes, to move to the, yes, in this case, what to do. And we have seen a very severe bladder situation with a severe reflux that before we don't have, and also we see a lot of many diverticula. That means that there is a severe alteration of the bladder wall, and also there is okay, the urodynamics, we have the dysfunction, and of course we know that it's not so common to perform in Ukraine. And regarding your recommendation, and of course, I believe that here could be helpful to have a connection between, in my opinion, between the recommendation of the guidelines and also the clinical situation in the specific area, because I think that correctly you put in the suggested management also the derivation and incontinence stoma or versus continent, because of course this could be useful in case that there is no opportunity to perform anticholinergics or Botox, to perform augmentation. So it's something that is in an emergency, but in order to save the renal function of the patients. And do you have any comments, Dr. Zymak, for these patients?
No, thank you.
Professor Stein, do you?
Yeah. I think with this bladder, when you look at the picture and have this wall-thick bladder, non-compliant bladder, I think with there is no more chance to get it reversed, even with Botox and all these things. So I think this bladder contains much more collagen and not very much muscle. So, and we know that Botox and all these things would not work well in the long run. In the short run, we have very good experience with nighttime drainage, where you can at least manage it for part of the time. But I think in the end, this will end up with some urinary diversion, means either what you depends on what you like and also what the patients like. It's not also on the related to the opportunities you have in your country, and it's also related to the patient. Is he really able to do a CIC? Is he really willing to do a CIC? And when you see this patient, he's 10, or when he's even older, he started with doing CIC and getting anticholinergics, but he stopped to do it and he ended up with this. So he's maybe not very reliable to this. And then you may even think about incontinent diversion in this patient, which makes the bladders, makes the situation safe for the kidneys. And one option would be also to put in an ileal or a colonic chimney to the bladder, which makes a temporary incontinent diversion until you may change to a continent diversion, or you may change to a complete incontinent diversion, because when you do a conduit, then the bladder is more or less out, and even in these patients, there is some risk for bladder cancer later on. So you have to discuss, if you do a conduit diversion and the final solution, I think you have to discuss also taking out at least most part of the bladders to avoid any cancer in the future. So this is something to discuss with the patient, and it's not only related to the country where we are in the opportunity, it's also related to the patient.
Thank you very much for your comment, Professor Stein. I totally agree with you. I've seen a comment from Dr. Shevchuk from the St. Nicholas Children's Hospital Lviv, and they have a urodynamic, and this is very important to know. And I believe that we have to share knowledge between us in order to better understand how is the exact situation. And for this, I believe that Omnet will be very helpful for us. And I believe that we can move to the second presentation. I would like to introduce Dr. Pulvirenti, that will present the second case of the neurogenic bladder. Please, Dr. Pulvirenti, the podium is yours.
Good evening, everyone, and thank you. I will now share my screen as well. Okay, hopefully you can all see the slides. Okay, so once again, I will present a case that aims to exemplify what a CPMS discussion can be. And again, it will be a neurogenic bladder case secondary to an occult spina bifida. So the patient I'm going to talk to you about is a 3-year-old suffering from lower anorectal malformation and anteriorized anus that was followed up at a different hospital. She was on active follow-up and home anal calibrations. However, at the age of 3, she joined our outpatient clinic with parents reporting urinary incontinence without history of urinary tract infection and irregular bowel management. So based on the clinical history and the anatomical situation reported, we started with an abdominal ultrasound showing normal kidneys and an empty bladder. And of course, we went for a physical examination showing an hypospadic urethra, anteriorized anus, a sacroprocedural dimple, and throughout the examination, we had a continuous urine dribbling. So based on these findings, we proceeded with further diagnostic, starting from a spinal MRI showing, as you can see from the image, a syringomyelic cavity and a lipoma of the terminal filum. And we also went for a cystoscopy and vaginoscopy showing, well, the cystoscopy part, a small-sized bladder with a gaping neck, and a suspect of ectopic left ureter. On the vaginoscopy side, we did find a vaginal septum with 2 hemivaginas. And we also proceeded with a urodynamic evaluation showing, as you can see from the graph here, a very low bladder compliance with leakage starting after 15 milliliters injected only, despite a catheter being placed. So with this kind of information, I think the floor could be already open for a CPMS discussion, as there are several points that may be discussed for these patients on how to proceed, as the ones that are listed. So whether to start or not antibiotic prophylaxis, whether to go for further diagnostic, whether a detethering procedure is needed, or how to manage the urological situation, thinking, for example, to clean catheterization and oxybutynin to give some time to the bladder to grow. So our clinical decision in this case was to go for further diagnostic, repeating an MRI, and to start with clean catheterization while waiting for surgery. However, despite providing the patient the next appointment, what happened is that we lost her at follow-up for 7 years, and she only came back at the age of 10 at the outpatient clinic, reporting the exact same symptoms as the first time. So persistent urinary incontinence, still without history of urinary tract infections. So once again, since the time frame, we started with investigation, going again for a cystoscopy and vaginoscopy. At cystoscopy, the situation was basically superposable to the previous one. So small bladder with gaping neck. But this time we couldn't find any evidence of the urethral metastasis. We didn't see the right one, while the left one was seen in an ectopic position below the bladder neck. And well, since finding the left meatus, we performed a pyelography from the meatus itself, showing an incomplete duplex system with a bifid pelvis that was further confirmed by an abdominal MRI and actually bilaterally. The last thing we did as diagnostic was a scintigraphy showing an overall normal kidney function. So again, we believe that this case really exemplifies something that you could discuss on the CPMS. In our opinion, there are several discussion points on the potential treatments that could be discussed with international experts, starting from whether a new MRI is needed, because the previous one is from 7 years ago at least. Whether we should opt for a conservative management that we never tried since we lost the patient at follow-up, with clean catheterization, if there's room for using bulking agents or Botox, although because of the new defined anatomical situation with the urethral metastasis, we think these two options may be excluded. What to do when it comes to reconstructive surgery, how to manage the urological surgery part, and when the tethering should be considered. So in our opinion, what could really be discussed together is, of course, the time of surgery based on probably the new MRI, whether to start with the spinal part or the urological part, whether the urological management should be addressed with a one-step approach or a two-step approach, and of course, which interventions are more indicated for this specific patient, and how to best treat the anatomical situation and the functional situation that we encountered. This is the case. Thank you for the possibility to present it. And yeah, if there are any questions or discussion here.
Pulvirenti for this presentation.
Thank you. And we have some points that we can discuss and will be helpful for the CPMS discussion. And first point could be useful to remember that, of course, we can discuss between urologists, but when we talk about spinal bifida patients, we have to discuss in a multidisciplinary way. So please consider that, for example, that if there is an MRI, that there is some doubt about the tethering, especially if we are talking about ocultospinal dystrophies, and the platform could be useful to evaluate together MRI with other radiologists or with other neurosurgeons. Other point is regarding the cystoscopy, and the suggestion sometimes could be, as in this case, to repeat an endoscopy, because in many cases, it's quite common, I suppose, everywhere, in Ukraine too, that the patients moved between one center and another one, sometimes to obtain a second evaluation, and some invasive evaluation has been performed in a previous center. And if you don't have a so clear situation, the suggestion could be, for example, to repeat the exam in order to have exactly knowledge of the situation. And I avoid because we have very few minutes, the comments of the surgical choice. And do you have any comments, Dr. Zymak or Professor Stein?
Just now I am thinking about additional genetical tests as a medical geneticist. Maybe Some our Ukrainian urologists have any comments and reactions? Please
Yes.
share.
And if the question is related to the fact that we can obtain also genetic consultation, I believe yes. And the platform is for a multidisciplinary approach because we are talking about patients that need a multidisciplinary approach. Do you have any comment, Professor Stein, or otherwise we would like to move with the third case presentation?
Just a short comment to the tethered cord is that the indication for untethering is neurological symptoms or pain or these things or changes in the bladder. Changes in the bladder is excluded with this case because you have almost no bladder or no bladder neck. So this is something there. And so repeat an MRI, yes, for the tethered cord, but on the other hand, you have to do a very thoughtful clinical investigation from the neurological point of standpoint, because then you have maybe an indication for untethering, but I guess in this case you don't have any good indication for an untethering, so it goes just to the urological part.
Thank you very much. And we had a short comment for the previous case by Dr. Abelardo. Thanks that is stressing the fact to consider the renal function and about the DMS3 radiography. Yes, of course, is useful and is useful to pay attention to the renal function and considering all the limits also of the serum creatinine respect to cystatin C. And Dr. Weil, please, do you like to present the last case, please?
Okay, let's see. Again, I will share the screen. Okay, so my second case is a 4-year-old male. He was suspected with tethered cord, and the parents, they noticed that he's not really peeing normal. He's always kind of holding his belly and he's like pressing really hard, and that's the way he urinates. And he's now had a first febrile UTI 2 months ago. It was necessary for him to stay in a clinic and receive IV antibiotics. And that's how this VCUG was created, because they did further diagnostic. And now the question arises, what is going on with this bladder and why is he peeing other than usual? And again, we did perform a urodynamic, so that's why I really want to keep it short, since this is not really the main point of discussion, the urodynamic, but here we do see a bladder volume which is really very low for a 4-year-old, and we do see a very rising pressure from a very low filling with 30 milliliters. He's already going up to a pressure of 40 or even up to 50 centimeters of water. So this is the findings we do have. We have a reduced compliance, though we do not have reference for children. And so my questions now would have been, should we first ask the neurosurgeons about detethering, or should we first start with a urological management? And again, here, do we start with CIC with a 4-year-old? This can be quite challenging. And what about anticholinergics? Again, here, oxybutynin, or what would be the preferred medication? Or should we maybe even first place a suprapubic catheter until the CIC is established, just to really take off the pressure from the system? And what about the reflux? Should we put the patient on a prophylaxis? Because now if he starts CIC, he might even get more infections. Or do we do a surgery like a urethral reimplant for a neurogenic bladder? So, and that's at the end of my presentation.
Thank you very much, and for this presentation, very helpful for all, and I believe that we offered the different cases and with different conditions, but I believe that of course what we have to start in the next future, and we know that the platform is active, and so we can decide to start from the next month and to discuss cases. And one recommendation, and to not be shy, and to be we have to start, and we have to start together, and I believe that we could use this platform. And Dr. Zymak, do you have any comment?
I would like to thank you to our European colleagues for providing this great opportunity. And access to CPMS is for Ukrainian specialists is very, very useful. I encourage our Ukrainian colleagues to join and actively use this platform.
Thank you. Professor Stein, do you have any comments? No? Okay, thank you very much. And I would like to recommend, and one question more. Yeah, okay, it's a thank you. Thanks. And thanks to all the participants, and please consider that Darren, with his experience for all the technical aspects, is here, and is here to help you. And I believe that we can define together, Dr. Zymak, and one day for months at the beginning for discussion the cases. And I hope that Professor Stein and Professor Faith, that I've seen in the participants, will be present as experts to help us to discuss. And we have also, I've seen other colleagues, and Professor Taskinen, and also, of course, the young colleagues, Professor Dr. Weil and Dr. Rebecca Pulvirenti. Thank you very much to all. Thanks again to Omninet and to International Federation of Spinal Bifida, and of course to all the staff of Eurogen. And we will come back in the next month with another webinar, but also with the CPMS discussion of the patients. Thank you very much to all. Bye.
Thank you, and see you soon.